Welcome back, everybody, to the Dose Adjustment Podcast. Today, we are talking about the root of modern disease, and that is metabolic dysfunction.
Our metabolism kind of is the engine in which we burn fuel and use fuel in our body. It takes more metabolic energy to turn beef jerky into sugar than it takes to turn gummy bears into sugar.
Having better glucose control, lower glucose levels, less sugar intake is going to positively drive the reduction in metabolic disease, cancer.
Without a doubt.
The information provided in this podcast is for educational and informational purposes only, and it does not establish a physician-patient or pharmacist-patient relationship. The opinions expressed by the hosts and guests are their own and do not constitute medical advice. This content is not intended to diagnose, treat, cure, or prevent any medical condition. Always consult with a licensed healthcare provider in your area before making any changes to your personal healthcare regimen or acting on any medical information shared in this podcast.
Welcome back, everybody, to the Dose Adjustment Podcast. My name is Amir Rahemi. My co-host today, Kris Hasenauer. Thanks for joining me.
Yeah.
Today, we are talking about the root of modern disease, and that is metabolic dysfunction. So my thoughts on this is, as Americans, right, we're not just tired and overworked. We are literally being poisoned day after day by sugars, seed oils, overstimulation, all these things that we've talked about. And it is making this nation sicker and sicker and sicker. And not only is it affecting us as adults, affecting our patient populations that we work with day in and day out, but we're starting to also see this in younger ages as well. Yeah. And the statistics vary, but I see anything from 18% of children conservatively on the CDC website have a chronic disease, up to some estimates of almost 40% of children in the US have a chronic disease already. And while today we're going to focus more on men's health, our adult health, this is a huge problem that we have in our country. And the more that we do the research, the more that we are talking to patients, the more that we are seeing the different labs, we are realizing that the root of this is metabolic dysfunction. So with that said, let's define metabolic disease and what we can do about it.
Right on. So metabolic disease, right? We talk about it as the sense of, what's our metabolism, right? Our metabolism kind of is the engine in which we burn fuel and use fuel in our body.
Sure.
Right? So if you think of it like an engine, sugar's the gas, sugar is fuel. So we take in food is the fuel for what we've got, right? So we're breaking it down. So you need to break down carbs, protein, fiber to fuel your body. When we do that, the end state for our brain is always glucose, always. Brain burns glucose, period. So there's multiple metabolic processes that get us there. Now, if you think about your cells and then you think about insulin. Insulin is a chemical, it's hormone secreted in our body. You got sugar, you got the gas tank, you got to feed the engine. Well, insulin's the key to the gas cap for all your cells.
Right.
Opens the gas cap up, sugar can go in, glucose, sugar, glucose, same, okay? Yep. Feeds the cell, right? Now, what happens when you don't have enough keys, insulin, to open up all the gas caps, or you have too much sugar? One of those two things, right?
Right.
So now you have this fuel that's just sitting, right? And it's not actually acting on anything. It's okay, you need XYZ amount of fuel to run this cell. Well, then it's like, okay, that's in there, but there's all this other sugar here. The body's like, well, what am I going to do with this? I'm going to turn it into fat. Right. The body's like, we're going to store it. So you're kind of doing two things on yourself here. You are running through your insulin because I think we have a finite amount that our body's going to make over our lifetime, and every time we take in sweet, sugary stuff, we trigger it, and our body releases it, and they're like, boom, 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 here we go. We need more. We need more. Now and then. So since we eat too many calories, we eat shitty calories. The quality of our food is crap, and now our body's going to store this crappy quality food as visceral fat.
Right.
And then you have this BMI change. So now we've overtaxed with sugar. We have poor insulin control, so we can't fuel our car appropriately because it's got water in the gas, or however you want to continue with the analogy.
Yep.
And then we're trying to pull an extra load. So now we're trying to pull a trailer with this shitty engine.
Yep.
Right? So we're just overtaxing the engine. We're overtaxing again. And then we look at like our triglycerides and our HDLs, and now we're affecting the fuel that we're using because cholesterol. So meta is necessary as a chemical component of all our body's metabolic processes. You know, our brains need cholesterol, our hormones are cholesterol based. All of these things need these cholesterol. So there's this huge kind of misunderstanding of what cholesterol is. Like, we need it.
Yes. We'll die without it?
We'll die without
Literally.
cholesterol, right? But everybody's like, oh, you got to block, you got to do this. Well, if you eat right, that's one component of it. So diet is one component. Genetics are another component. Hormone optimization is another component. You have all these things in pieces. So then you want your numbers right. So we'll look at the numbers, like the ratio numbers of cholesterol and why they matter, right? So kind of look at our triglycerides. Mm-hmm. Triglycerides are essentially the breakdown of junk food. Triglycerides are shitty food. Yep. That's it. Bottom line, like, that's Cheetos, that's your sugar, that's your refined carbs. It's like, triglycerides are whatever they are, fatty acids and different things, but that's what they ultimately come out to be. So you want a ratio of HDL, high density lipoproteins.
Also known as good cholesterol.
Good cholesterol.
Right? Debatable
right?
if that's what we should call it, but good cholesterol.
Yeah,
Yep.
right? To triglycerides, and you want a lower ratio, typically between 2 and 4. Mm-hmm. If you're outside of that ratio, you have an increased risk of heart attack, stroke, metabolic, obviously we're talking about metabolic syndrome. All these things are kind of attacking your body.
Yeah, and just for listeners, we're trying to understand the ratio, right? So it's kind of the numerator denominator thing. So we can either lower triglycerides or increase HDL.
Yep.
Or you can work on them simultaneously by having an active lifestyle and also reducing the low quality food that we're eating, mainly sugar, alcohol, seed oils, empty calories, things like that.
Empty calories, right. So that's what we're doing. So quality things, right? Because even when we look at keto, right? We're like, oh, I'm on keto. Your body's still, okay, so how does keto work? Here's how keto works in like 100 words or less. It takes more metabolic energy to turn beef jerky into sugar than it takes to turn gummy bears into sugar.
Sure.
That's it.
Makes sense.
That's keto.
Yep.
Right? You take and burn calories to digest food.
Yeah.
Right? So when you have to turn beef jerky into glucose to feed your cells and use ketones to do that process and all the things that go with it, you are going to burn more calories.
100%. So to just, I think, circle back to why this matters and why this is a really big deal in the country. Statistics show that 1 in 3 adults in this country have metabolic syndrome.
Absolutely.
1 in 3. And most likely they don't know it, right? So there's 3 of us in this room here. Looking around the room, I think we all are doing the right things, getting after it in the right way. But in the general population, if there's 3 people sitting next together, 1 of them have metabolic syndrome. And what is the downstream risk of that, right? So when we look at heart attacks or cardiovascular disease, you are twice as likely to die from a cardiovascular event in the following year if you have metabolic syndrome. There was a litany of increased cancer risk. So colorectal cancer, 33% increase, right? Pancreatic cancer, 58% increase. For women who are postmenopausal, 56% increase in risk. And it goes on and on. There's some Alzheimer's and dementia risk associated too.
Absolutely. So okay, let's break it down. Colorectal cancer. What are we doing? We're dumping sugar. We're dumping fuel into damaged cancer cells. We're giving them a food source to feed. Yep. Right? I mean, so you look at, so the complete inverse of what we're talking about, metabolic syndrome, would be fasting, right? And Mayo Clinic, everybody in India, the research institutes on cancer and all that stuff, I've been using significant fasting diets to reduce cancer load and cancer on the body. So there's absolutely that, but you're feeding the cancer. Cancer loves sugar.
Yeah, and I'm not an oncologist, and I don't claim to be any sort of cancer expert, but everything that I read and see when I listen to medical professionals speak about cancer, it does seem to come back to this fasting or significant sugar reduction. And what I don't know, and an expert would, is there are certain type of cancers that are more responsive to that than others. But it seems to me that we can say holistically, having better glucose control, lower glucose levels, less sugar intake is going to positively drive the reduction in metabolic disease, cancer,
without a doubt.
heart disease.
Yeah, without a doubt. So you look at that. So it's sugar is the culprit, and how does it get there? I mean, even sugar in the idea of blood pressure, right?
Yep.
So we look at like osmosis and how you do, and like, oh, salt causes high blood pressure. Well, electrolytes are transient as they can be. You go for a walk outside, and you're going to burn through electrolytes.
Sure.
You're going to sweat them out.
Sure.
Right. So yes, you should have a controlled DASH diet and all this stuff, but
without salt, you would die.
Without salt, you would die. Without, exactly. And then there's the idea of, well, what's the sugar load on the diet?
Yeah.
Remove the sugar load, but we're not going to come out against. I mean, Domino's Sugar is the biggest cartel in the world.
Yeah.
Without a doubt, right? Like sugar is everything. It's Coke, it's Pepsi, it's Snickers, it is in everything. I mean, now they're redesigning it so that it fights through GLP-1s, like Ozempic, Mounjaro. They're redesigning sugar so that those meds don't work to make you not want it. I mean, so there's this. You just have to recognize what it is.
Yeah.
And
you brought up blood pressure too, and I'd kind of gone down the rabbit hole on this a couple of years ago, and the same pathway so insulin will bind to a receptor, right, and it will start a cascade that will allow sugar to enter the cell. Like it's the basic how it works. And over time, if you are secreting more and more insulin, your body making its best attempt to get the glucose out of the blood, these receptors can become less sensitive.
Absolutely.
And it's the same mechanism that allows the glucose to go into the cell that also produces nitric oxide, which allows for vasodilation. And once that's desensitized by the high sugar, by the high insulin, you're also losing your ability to vasodilate.
Yep.
I.e. the blood pressure issue and then the cardiovascular issue. And it plays out. You're twice as likely to die from a cardiovascular event.
So you have all those things, right? So you can't control the pressure of the pipes. So you think about from a plumbing standpoint, you look at like old copper pipes and you got all that buildup inside and the water pressure is like kind of crappy or whatever. To get new, you replumb the house and the water pressure's up, everything. But that's what you're doing. So you now have this, because what is the law of fluid dynamics? If you increase the diameter of a tube by 1, the fluid increases by 4.
Yep.
Well, the inverse is true. So if you make it a narrower tube, the pressure is going to go by that same factor. So that's your blood pressure, stress on the pipes. So what do we have when we also have a stroke or heart attack, right? You get like a pinhole leak.
Yep.
It pops.
Yeah, 100%. Okay, so the idea here, metabolic syndrome is the driver of many other diseases. We already talked about cardiovascular disease. We talked about cancer. We talked about dementia and Alzheimer's being at a higher risk. There's really good data to suggest that there's a 30 to 60% higher rate of depression in people with metabolic syndrome. And I don't know if that's directly tied to the fact that there is insulin resistance in these chronic diseases, or is it just the type of individual that you've become? You've become sedentary. You're watching Netflix for hours on end.
But I think that's a part of it. So you're not exercising, your diet's crap, you're doing these things, but then what else does sugar give you? Dopamine dump.
Yeah, correct.
So you're triggering essentially an addictive behavior over just, sugar is absolutely addictive.
Yep.
Don't care who you are, you have sugar, like to detox from sugar takes 7 to 10 days to really not feel it, right? So you're getting that dopamine hit. You're getting those things that are coming in and they're changing your behaviors, right? I mean, just look at little kids. Everybody talks about it. You give a kid sugar and they go ballistic, then they crash and act like an asshole.
Yep.
Right?
Yep.
Because they're going through withdrawal.
Pretty predictable. Yeah, pathway for sure.
Yeah.
Last and not least, we'll talk a little bit about infertility and lower testosterone levels. I think testosterone in men is a really huge deal, right? It's what gives us our energy to go throughout the day. It allows us to burn fat, to hold additional muscle. The more muscle we have, the more insulin sensitive we're going to be, the better our glucose levels are going to be, the less likely we're to have metabolic syndrome. For most of us, I think when we start to hit our age, testosterone is a huge deal. And of course, there's replacement opportunities, right?
Yep.
But if we can keep guys, from 26 to 42 producing their own testosterone, that seems to be the best way to go. Or minor pharmacological intervention with something like enclomiphene, test fires, things of those nature.
No, absolutely. And like you're adding, again, this kind of goes back. What can we do that is operator level treatment. You control what you put in your mouth. You control what you eat. Now, there's obviously socioeconomic binders and stuff like that, but then, you know, that's the shitty thing that junk food, shit food is our cheap food.
Yep.
Like, that's crazy. But then we look at these things, but it is by design because you push it in volume, push it in bulk, and all these things. Now, we know you look at like visceral fat, getting your testosterone up is going to help you burn off that visceral fat. When your testosterone is low, you're going to store it.
Yeah.
Right. That's just part of what's happening. The metabolic processes of your body are not optimized when you have this. That's the whole, literally in the name, right?
Yep.
So that's the thing you're going back to attack. And you may have to take those one at a time, but they can absolutely all be taken care of in a treatment plan, an exercise plan, a diet plan. You can see phenomenal results. Like, I've seen them, you've seen them. We have patients that we go in and we're like, do X, Y, Z, and you get that patient that is ultimately, I'm going to do what you told me to do. I'm going to come back. I'm going to tell you how well it's working. We're going to tweak it. We're going to do that. We're going to tweak it again. And we just keep working with you. And you can reverse this. If you were at a place where you just have metabolic syndrome and it's not turned into diabetes, it's not turned into significant coronary artery disease, and you're in that just getting to the top of the hill where you're about to fall off the other side, we can take you back down.
Yeah.
Watch it every day.
Yeah, 100%. And I think if you are in that place where you've already been diagnosed as a diabetic, diabetes is a wide range, in my opinion.
Yep.
And not saying that it can be completely reversed. So there are some cases where we see that if they're not too far progressed, you can get down to the lowest dose of a really safe and effective medication.
Or off of insulin.
Yeah,
It's
100%.
possible, like, to get off of insulin. It's case by case basis, but I've seen it. We do it, and it's
Yeah, I think you're right. Really, it comes down to whether they still have this beta cell function or not.
If you have functional beta cells and you can control your diet and you can they make yourself more insulin sensitive and all the different things you can do.
Yeah.
There are absolutely places to do it.
And more and more, I'm a fan of reducing insulin when possible, because what we find is when you give that insulin dose, yes, it will reduce the blood sugar, which is actually really good for the small arteries and vessels, right?
Mm-hmm.
Having lower blood sugar is great. But what we find is when you have high levels of insulin, right, it's not so good for your major arterial system.
Yeah.
So yes, you don't have kidney disease and your eyes are not going bad. However, you're still likely to die of a heart attack due to this hyperinsulin nature.
Yeah.
In addition, right, so as soon as insulin hits the blood, right, your fat cells are going to stop the process of lipolysis, I think,
Yep.
right? So they're going to stop releasing
Yep.
that into the system. And so for a lot of us who are trying to lose weight, it can be very difficult when on insulin.
Yeah, because you're at that place where you're like, all right, we have released insulin, so we know because we released insulin, we have just got fed.
Yep.
We have fuel. So now we don't have to metabolically tap into our body's starvation resource, which is our body fat.
Yep.
Right? Because when you're burning fat, your body's like, oh shit, we don't have anything to eat. We got to do X, Y, Z. Well, if you're overweight, you have to keep your body there so that you can lose the weight. But from an evolutionary standpoint, fat is a tool. It's a survival tool.
Yeah. Yeah. When you look at the system as a whole, right, it's kind of genius the way
Yeah.
that it works, because at the end of the day, if you're hunting, right, we might have some deer meat today. We might have some rabbit meat tomorrow. We might have some berries, and not many of them, I bet.
Yeah.
So pretty genius the way it works there. So yeah, a huge fan when there is good beta cell function, if we can reduce people off insulin with non-pharmacy mechanisms, or at least reduce them, I think is a big thing.
Mm-hmm.
What's your stance on metformin? I am a metformin fan, but you see the other side of the coin. What do you like there?
So I guess where I am for the insulin sensitivity part and where you can do it, I definitely think it's something you can get people on to improve their metabolic function with the intent of, again, taking them off of it.
Yeah, 100%.
Like that is always my intent. If I get you on something and I'm like, okay, if we can correct this by doing X, Y, Z, or at least bring you off of it for a while, because you may get to the point where, yeah, this is just you bought and paid for that, right? Like that's where you're at in your life. But
Yep.
always trying to take you back to diet, exercise, nutrition, and fix it. Side effects. Most people become non-compliant with metformin because of side effects.
Yeah, early 2 weeks, nausea,
Yeah.
vomiting, diarrhea. If you can take some food, a lot of times you can get over the hump there. And just so people know, the primary, I think we usually put people on metformin first. One, it's super inexpensive. And two, the way the drug works essentially will block absorption of glucose from the GI system.
Yep.
So less sugar going into the tank. Now it is staying in the GI tract, which might not be good for other cancers and things of that nature. But
because you're feeding that gut microbiome, so you're going to get those, which is where you're getting those gastrointestinal symptoms, right? Because you're feeding the microbiome, you're changing the biodiversity, because all of that. So it does come down to that. Everything that you put in your body is a trade-off.
Yep, 100%.
So what do you want to do for your performance, for the way that you feel to get you the best that you can be?
Absolutely.
And you may be, an insulin user, and that may be a thing, or you're a type 1 diabetic and you just don't make it, and we have to say, okay, but here's how we make you do X, Y, Z, and this is your schedule, and this is the diet. And is it difficult? 100%.
Yeah.
But it's a lot less difficult to do the hard work now than to be at that place where your feet are swollen, you're getting an amputated foot, you're in a wheel like that. That's hard.
Yeah,
That's the
100%
hard
agree.
place.
And that's the end state of all this, right?
Yeah.
If you happen to not be the guy who died from the heart attack and you didn't get cancer and you didn't have a major depressive disorder, your foot ends up getting cut off at some point, you lose your sight.
And that's what we're talking about too, like dying in the wrong order.
Dying in the wrong order.
Like we're dying out of order. That thing, like you're rotting before you're dead.
Yeah, no, 100% agree. I will say that I do see what I believe is a lot of overprescribing of insulin, even in type 1 diabetics. If I remember back to, at least this was the education 10 years ago, our body naturally produces about 35 to 40 units of insulin a day. And I'll see type 1 and type 2 diabetics being prescribed, 150, 200 units of insulin. And I think it's having a detrimental effect. So having good PCP.
Well, because you have it where you get diabetics that will take it and they're giving it as like here, take it. It's a safety measure. Well, I'm going to go eat this. So instead of accountability, they're using it as a tool to do the things they shouldn't be doing.
You're absolutely right. And I should have mentioned that's 100% is so I can eat whatever I want, and this keeps me where I need to be because they're treating the number.
Because they're treating number because they're treating the safety of which they are. I mean, it is safety because you don't want to have hypoglycemic event where you can be dangerous, or hyperglycemic event or ketoacidosis or anything. So, but you're treating a number and not treating the patient.
Yeah.
Be like, because that's where you have the hard conversation. Hey, this is what you make. This is where you're at. You have to control your diet, or you're just going to do like if you're using your insulin pen to eat at Dairy Queen and McDonald's, we need to talk about what.
And I think if we rewind it back 20, 25 years ago, I remember my grandma and grandpa, we would literally pull into the Wendy's parking lot and they would test grandpa's sugar, and if it was at a certain level, he could have a Frosty.
Yeah.
And of course, the understanding was very low back then. We didn't know what we knew today, or she didn't know at that time, but that's kind of idea. It's like, hey, we took the insulin, we got it low.
Yeah.
Let's rip off on some Frosties. So sugar's a culprit. So at the end of the day, I think what we're both trying to say here is you have a huge opportunity to reverse or prevent disease now if you know the right things to focus in on. So with that said, if we look at how do we diagnose metabolic syndrome, there are 5 criteria to it. Do you want to take us through it, and then what is it? How do they classify whether you have it or not?
All right, so we're going to go down the list. Men, waist circumference, over 40 inches, right? Women, 35 inches. Waist circumference is not at your hips. It is your belly button around here. Your waist is up here. Okay. Like that's, military standard waist measurement, right? Elevated triglycerides. Again, we talked about triglycerides being the breakdown of essentially junk food. I mean, you're going to have triglycerides and everything. They are metabolic, but when we have a shitty diet, triglycerides go up, right? Low HDL cholesterol, or what we call good cholesterol, right? Meaning less than 40 milligrams per deciliter and less than 50 in women. Or are you on treatment for your HDL?
Yep.
Right? What are you taking a statin? Are you on fenofibrate? Are we looking at these medications to treat a cholesterol condition? Elevated blood pressure, because that goes back to the sugar, right? We're driving that sugar into the plumbing. We're upping the pressure in the pipes. That pressure is going to go up. Do you have that? So you're overstressing the pipes. You have, you're carrying extra weight around your midsection, that visceral fat. So again, we're not getting the fuel to the cells. We're dragging extra weight on the engine. and now it's skipping a beat. The pistons aren't hitting, right? And then elevated fasting glucose, because as we eat, our body is designed to control these glucose spikes with the insulin so that we have a steady state level of fuel in the tank, right? So we're not overdriving the system. And once you have lost the ability with the beta cells, the insulin receptors, the things you've got, once you've lost that ability, we're gonna have these elevated glucose because our body isn't compensating for that rise in sugar. So those things drive it. But the worst thing about every single thing on there, except for maybe the waist circumference, you don't feel any of it.
Right.
There are no physical feeling symptoms. It just is happening.
Yeah.
Like silent killers.
And we deal a lot with that in compliance in the pharmacy world, right? Because you don't necessarily feel that your blood pressure is elevated or that your sugar is elevated. And so people are like, I'll take it, I won't take it. It's very clear to us as pharmacists. We can see the last time you filled it, how many days you should have had. But compliance is a huge issue because you're not feeling it. And that's why we're sounding the alarm. 1 in 3 Americans, 1 in 3 of you have metabolic syndrome. You're twice as likely to die next year of a heart attack. It's a huge deal. And that's why we're trying to bring so much attention to it today.
Yeah.
Now, so you mentioned 5 criteria, right? And so the standard definition of metabolic syndrome is having any 3 of those.
Yep.
So you could be on treatment for high blood pressure. You could be on cholesterol treatment and have a waist circumference of greater than 40 inches.
40 inches from it.
You've got metabolic syndrome. You are at increased risk. Cancer, heart disease, dementia, depression is a really huge deal, and it is so solvable with minor pharmaceutical intervention, potentially, or maybe even just lifestyle and diet adjustment. And this is something where I think you've got to dig in with your primary care provider. If they're worth their salt at all, they're going to be helping you navigating this.
And I mean, the information is so easily accessible. Right? Everybody's got a phone. You can just look it up and say, what should I eat to lose this? So, because when we talk about diet and exercise, we talk about this. Here's your diet, right? Your ideal body weight times 12 is your caloric intake.
Ideal body weight times 12
is caloric intake.
Caloric intake, okay.
50% of those calories need to be protein.
Yep.
30% need to be fat. 20% need to be carbs. You will fix this problem.
Keep it simple.
Keep it simple.
Stay away from alcohol. Stay away from sugar.
Yeah. So I mean, if you
numbers.
Yeah. So if you can drink water and black coffee, that eliminates so many empty calories out of your diet.
Yep.
Right. So you've taken that. So then it's just the food you eat. Right. You hit those numbers. You do it. Now we'll dive into it on the diet nutrition thing, and we'll dive into a lot of it, but then try to simplify it down, because ultimately every diet nutrition book, textbook, internet fad, whatever is coming up against ultimately 3 things you digest: proteins, carbs, and fats.
Yep.
And the ratio in which you break them down, how you feel. Calories are how much you weigh. Macronutrients are how you look. Micronutrients are how you feel. You dial those things in, you're good.
100%. We're seeing a rise in non-alcoholic fatty liver disease. I think it deserves its own entire episode, but the numbers are pretty staggering as well, and I think it ties right into the metabolic syndrome. Typical labs that you'll run for people in relation to this?
So we will look, obviously, glucose, run insulin, hemoglobin A1C, all of your lipids, like your full lipid profile. CRPs for inflammatory studies can be done. Kind of just build it into our men's health profile that we have. So we and then if we get something that triggers a deep dive, we'll go further into it.
Right. One thing that I was talking to you about earlier that I know we've both been toying with this idea, but is continuous glucose monitoring. So as everybody sees, I've got one here. I'm not diabetic, but I'm super interested in what's going on with my blood sugars, especially when I eat different foods. I find it as an accountability tool for myself, but I know that patients are now actually sharing data with their primary care providers or their health coaches.
I love it. Like the patients that I have that are on glucose monitors have it on their app when they come in. I'm like, all right, let's see it. And we can go through and scroll through 3 months of data points. And like, okay, what was going on here?
Yeah.
Oh, I was on a cruise, like whatever. And they can backtrack it. And without really diving into what is it really doing? Glucose monitor, so it's giving you your sugar, right? It's giving you this number of sugar where you get these peaks and valleys. Well, hemoglobin A1C, right? Think of red blood cells like apples, right? And eventually, if you eat enough sugar, you caramel your apples, right? So a red blood cell lives for about 120 days. So if you control your sugar, the red blood cells, the apples, will not get carameled.
Right.
So that's what we're seeing. That's why a hemoglobin A1C is a good 3-month indicator of blood sugar control, because we are looking at how many carameled apples you have floating around in your body.
Yeah.
Because you can't get the caramel off, right? So it's there. So it has to go through the body's breakdown metabolic process of getting rid of those blood cells, where the cells die and the body breaks them down and gets them out, and you make new red blood cells. And then that has to do and then your ability to do that has to do with your other hormones and all of these other things, right? So that's how hemoglobin A1C gives us your diet, you're like, oh, your sugar's good today, but your diet's really been shitty for 3 months.
Yeah.
That's how we call you out on that.
Yeah,
that's
100%. And that's why I think I like this CGM, because the A1C is like a proxy, right?
Yeah.
Like it's a pretty good estimation of what your average has been. On this, like we were looking at some of my numbers earlier, you can just dial it in. You can see exactly what it was. And there's a margin of error, approximately, I think it's about 7% plus or minus, but it's still a really good indicator. But for me, if you're somebody who you take your health very seriously and you're looking to go to the next level, consider a continuous blood glucose monitor.
Well, they've even released one that's OTC.
Yeah, I was going to say the Freestyle 3s
you
can buy without a prescription. They are covered on a lot of insurance plans. If you happen to be diabetic, I believe on and off throughout the years, they will actually allow you to get a couple of them free. So just dial in Freestyle Libre, free testers. I know that many of my patients will grab a code, will get a prescription from their provider. Fascinating data, helps you to really understand what foods you eat and what that impact is on your blood glucose.
Yeah, like what's your glycemic control, and then it'll make you understand what glycemic index on foods is. Like you hear that in diets, and you look on the label, low glycemic index. Well, what's that really mean? And it's how much is that food, that intake, going to raise your blood sugar?
Yeah, and if you're a guy who's like, I don't want to say super competitive, but let's just say you're always trying to get ahead. You're always trying to get the advantage. You're holding yourself accountable. It's an amazing tool. I will literally not have ice cream, right? And I will not have a beer, and I will not have all these things because I have this amazing thing that I'm going to come back and show my provider, in 30 days, like I'm the man. Thank you, and we're high-fiving each other. So it can be a great accountability tool. You can reach out if you need help with that. We can get you set up. They're so easy now. It's right on your smart device. Literally takes a few minutes. The first day, it's not the most comfortable thing in the world. It's got a little needle that sticks into the skin. But I think a great tool in your tool belt. So,
absolutely.
How do we wrap this up? What's the takeaway message? What do men need to start doing today to prevent metabolic syndrome and the litany of bad crap that comes with it?
Go for a walk, cut sugar out of your diet, increase your protein intake, drink water.
That's
and talk to your doctor.
Yeah. All right, guys. Thank you for watching another episode of the Dose Adjustment Podcast. We will see you next time for episode 7, right here on the same channel. Have a good day, everyone.
The information provided in this podcast is for educational and informational purposes only, and it does not establish a physician-patient or pharmacist-patient relationship. The opinions expressed by the hosts and guests are their own and do not constitute medical advice. This content is not intended to diagnose, treat, cure, or prevent any medical condition. Always consult with a licensed healthcare provider in your area before making any changes to your personal healthcare regimen or acting on any medical information shared in this podcast.